The topic is the impending disaster, and I hope the disaster doesn't happen. So it was a 3-year-old boy from Madhya Pradesh who came to me walking with difficulty, night fever, weight loss, history of repeated falls, and grossly the power was 4 by 5. He was a walker and myelopathic. Looking at the X-ray, this is how it looked. And we can see that there is some destruction of the bone in the mid-dorsal spine and some level of kyphosis which was there. So an MRI was done, and MRI showed gross pus collection at the D6, D7 level and significant cord compression. The actual images showed a significant amount of pus as we see. And now with this kind of kid who is a walker, 3-year-old myelopathic, MRI showing cord compression, what next? So now we have 3 options: surgery, AKT and biopsy. So how many of, if we can have a raise of hand, who would go for surgery? Okay, we have 2 guys going for surgery. Who would start AKT? So we have a couple of them who would also start AKT, and who would do biopsy. So most of us will be doing biopsy. So that's what I decided to do, did a biopsy. But the patient went into the CT scan and all the relatives became so scared, they just ran away. And the patient got absconded. We know that it was a ticking time bomb which was about to explode any time, and the time bomb exploded. The patient comes back after 1 month, and this time he's not able to walk with just one new MRI which looks the same. And the father came with the kid in his hand. So now what next? So now who would do a biopsy now? Okay, anybody for surgery? So there are people who won't do anything. So biopsy again. So why biopsy? So we again have 3 options, and this time the patient was non-worker neurodeficit, and that is why he would actually need decompression and release of the compression. So surgery was planned. So we did pedicle screw fixation and transpedicular decompression. Followed by this kid was post-operative casting, and this is how he was 2 weeks post-op. That's how he was 6 weeks post-op, and that's how he is 6 months post-op. So the question comes is, could we plan surgery when we see the X-ray, and there are any signs that could predict the future? So yes, there are Dr. Rajshekharan's paper, which is widely accepted. There are spine at risk, and this is what should be done in all pediatric COX patients. So there are signs about facetal dislocation, retropulsion, lateral translation, and toppling. All of these can be seen on an X-ray, and this is what is going to actually predict the deformity, if this is going to happen or not. So in our case, there were 2 signs which were present. So one is there was some amount of retropulsion, as we can see here, and there was some toppling. Now the criteria is that 3 or more signs are something which is a prognostic factor for development of deformity. Here there were 2 signs. So what we did in the first about conserving and planning the biopsy was right. But when there comes neurological deficit, that's when we would actually want to do decompression and fixation. Now we have pediatric systems and pediatric implants available that don't impinge. So the take home is that first is pediatric TB is an aggressive disease which has to be managed differently. It needs close observation because it can progress to severe deformities. Biopsy is a must, and just AKT is not in today's world. We always need to look at spine at risk and which are prognostic indicators, and role of early prophylactic surgery. So prophylactic surgery is only and only possible and should be considered when we come to pediatric spine. Thank you.